Hello doctors, I am Dr. Shanmukh, your physiology faculty at Global Healthcare Academy. I welcome you all to today's image advantage session. So without any further delay, let us move ahead and see what it holds. So the first question here is hypertension increases the distance between which two points? Before answering the question, let us understand that this graph is showing a curve or a loop plotted against volume and pressure changes within the ventricle of the heart. So what it actually means here, at the point A, it is mitral valve opens. That means the blood is flowing from the atrium into the ventricle. It is filling the left ventricle till point C, and we call it as end diastolic volume here, this point C, where the mitral valve closes. From here the ventricular contraction begins, but there is increase in pressure but no volume change, so we call it as isovolumetric contraction. In the similar manner, once this the blood is rushed out across the aortic wall, it comes back to point F where aortic valve closes, and from here the ventricle starts to relax but without changing in volume. We call it as isovolumetric relaxation. In between these two lines is the stroke volume. In hypertension, what happens? The stroke volume remains same, but the afterload increases. That means the pressure against which the ventricle has to contract will increase. So we can say that safely, when the pressure against which the ventricle has to contract increases, from here the distance increases where the blood is rushed into the aorta. So there will be a movement of points from D and A. This distance will increase, and also B and C. This also will increase, making it the answer B. Next, 56-year-old patient with small cell carcinoma lung presented with seizures has urinary sodium 31 millimoles per liter. Which diagram represents his fluid compartments? These boxes which are shown represent the fluid compartments of the body, that is intracellular and extracellular fluid. Here we call this as Darrow-Yannet diagrams. Darrow-Yannet diagrams. So logically, our intracellular fluid occupies 2/3 and extracellular occupies 1/3, ECF and ICF, right? This is the fluid distribution. Now any change in the ECF will impact ICF, but ICF independently cannot be modulated. The fluid compartment, intracellular fluid compartment, cannot be directly affected or changed. Okay, the ICF responds to the changes within the ECF. So keeping that in mind, let us see what is happening. Here he says that urinary sodium excretion has increased, there is small cell carcinoma lung, and there are seizures. Dyselectrolytemia, probably hyponatremia, and small cell carcinoma lung should hit you with something called SIADH. It's a paraneoplastic syndrome of inappropriate antidiuretic hormone. It's a paraneoplastic syndrome. So what is happening here? If you take the blue lines, this Darrow-Yannet as the normal, we can say that, and a yellow one as the abnormal one, which we are going to plot. There is volume increase because of ADH, and there is also concentration decrease because of sodium excretion. So the concentration has decreased and the volume has increased. This is in the ECF. So what is happening to the ICF? In the ICF, it will respond. Comparatively, it is hypertonic. So the water will move from here to here, expanding the volume till when the concentrations become equal. So this is how the final diagram will look based on the body fluids. The answer is B. Moving ahead, the receptor activity shown in the figure represents which receptors? See here, there is a stimulus here right? There is a stimulus here and there is receptor potential and there is action potential. When the stimulus is off, there is receptor potential and there is action potential. In between these, there is no discharge from receptor or action. There are no action potentials produced. That means during this time, even if the stimulus is continuously present, there is no response from the receptor. That means the receptors have adapted. The receptors have adapted. How? Quick adaptation. That means they know that the stimulus is there and it's not harmful, you get adapted to. Just like you're putting on a shirt, it is there and you get adapted to the shirt, right? Wearing the shirt. So it's a fast adapting receptors. Among all these, P and M, Pacinian and Meissner's corpuscles are fast adapting, making the answer A, 1 and 2. Moving ahead. True about the structure A is. Let us identify structure A and structure B. A is, this is the B, and A is rod because it looks like a rod, and this looks like a cone, it is a cone. Cones, these are rods and cones are used for, they are the receptors of retina, right? So cones are for color vision and rods are for scotopic vision, right? So scotopic vision, it means it has the ability to see at night. In the night, the intensity of light will be very low. As we all know, you are able to identify the stars, stargazing, low intensity, and also the receptor should have low threshold. It should not require high threshold to depolarize or produce a action potential, right? So low threshold, making the answer low threshold and sensitive to low intensity light. The option is A. Simple. Okay. What type of visual loss is due to damage? This type of visual loss is due to damage at what part of the optic pathway? We see here both are on the right side. It is right sided homonymous. That means similar. Hemi, half is gone. Hemianopia means you cannot see. That side is gone. But there is a central half circle and we are making it a full circle. Central sparing. The center of the retina, we can call it as macula. That means macular sparing. Okay. Where does this occur and why? See, if you take this, if the lesion is at this point in the optic nerve, complete visual loss will be there on the right side. And if it is the optic tract, there will be homonymous hemianopia without any macular sparing. But if it is at the optic radiation, somewhere here, I'm changing the color, optic radiation, somewhere here, there will be homonymous hemianopia with macular sparing. Why is it? Because as you can see, this optic radiation here is being supplied by both posterior cerebral artery and middle cerebral artery. Okay. This occipital lobe tip, this one here, is the location of central or macular hemifields. Okay, it's a watershed area. So compromising both the arteries at once is very rare condition. So if there is any lesion at optic radiation, it will lead to macular sparing, making it the answer C. Let us move ahead. True about autoacoustic emissions. Let us identify the parts first. This A, B, C, they are labeled. A is outer hair cells and C is inner hair cells and B is tectorial membrane. Right. So autoacoustic emissions are a sound, or they are the waves produced by the outer hair cells picked up by a very specialized microphones placed in the external ear. So these autoacoustic emissions are produced by outer hair cells. In options, the question is asked, what will happen if there is some drug toxicity? Usually if there is a drug toxicity, what happens? Cell dies or malfunctions and there will be decrease in its activity. Let us see. Produced by A, yes, correct. Increases in amic acid toxicity? No. produced by A. Yes, correct, and reduces in streptomycin toxic. What is streptomycin? Streptomycin is a aminoglycoside. Okay, they damage the outer hair cells, and hence they can be, this autoacoustic emissions can be used to monitor the toxicity also, but it's a very lengthy and complicated process just to find out whether the drug is causing toxicity or not. Okay, we better take care of the doses. And moving ahead, about the image is, here an arterial pressure versus time is plotted on a graph. The 3 is diastolic blood pressure 80 and 1 is systolic blood pressure, and 2, it is closer to diastolic and away from systolic. Usually it is MAP, mean arterial pressure. It is closer to diastolic because diastolic occupies most of the cardiac cycle. 0.3 is the systole and 0.5 is the diastole. Okay, so maximum this mean arterial pressure will be leaning towards the diastolic blood pressure. And what is mean arterial blood pressure? It is the average pressure throughout the circulation. That means it is continuous. Whereas systolic blood pressure, it only occurs when there is a cardiac systole and there is a transient increase in pressure. Okay, so this MAP will be continuous. So MAP is the one which stimulates the baroreceptor continuously. If there is a change in mean arterial pressure, it is the key factor. It will be the only one to elicit a significant response in the baroreceptors. Okay, so 2 is MAP and key stimulus for baroreceptor reflex. That is option 2. Okay, about the levels in given image about spinal cord. Okay, the lesion is at 1. Perfect, at the level 1. Lesion is at 1. Every option is there. That means we can surely know that lesion is at 1. Before knowing what this lesion and all, we can understand that there is something, one half of the body, something is cut. Okay, usually if something is cut and this type of diagram is given, it is usually hemisection of spinal cord, that is Brown-Séquard syndrome, right? So let us see what will happen in the spinal cord pathways. Spinothalamic fibers will ascend up 1 to 2 segments on the same side and then cross to opposite side in the spinal cord, whereas dorsal column fibers will ascend on the same side and cross at the thalamus, near the thalamus, and ipsilateral corticospinal fibers that are coming from the cortex will descend on the same side because they are from the pyramid. They are pyramidal tract. They already crossed at the level of medulla and they will descend. So lesions at this point will cause opposite side spinothalamic fibers 1 or 2 segments below the level of lesion. This half, it is gone. Okay, I hope you understand. If half, if it is gone or some injury has taken place, it will lead to opposite side spinothalamic tract lesions 1 to 2 segments below the level of lesion, and ipsilateral same side dorsal column fibers, that is vibration and all, will be lost, and on the same side corticospinal fibers. See here, for this level we call it as level X. Okay, level X. For this level, at the same level the motor neurons will be damaged, leading to flaccidity and all, but that is lower motor neuron, but beneath that the corticospinal tract is also damaged, right? So that means upper motor neuron features will be there below the level of lesion. That is what we see here. See here, ipsilateral loss of all sensory modalities at the level of lesion, that is here. Okay, ipsilateral flaccid paralysis at the level of lesion here. Ipsilateral spastic paralysis below the lesion. Of course, upper motor neuron feature. Ipsilateral loss of vibration and position sense below the lesion. Yes, dorsal columns. Contralateral loss of pain and temperature below the lesion. Perfect. This is Brown-Séquard syndrome. So we can say lesion at 1, loss of vibration at 2, and flaccidity no. Lesion at 1, loss of motor function at 2, okay, and loss of touch pain temperature at 3, okay. Lesion at 1, loss of motor function at 2, loss of vibration proprioception no, okay. So that means you can say loss of proper motor function. He did not tell whether it is spastic or flaccid. So the option is B. Okay. Moving ahead. A 50-year-old male presented with syncope, muscle weakness, abdominal cramps, and half the ECG changes shown in the image. Truth about the condition. This ECG, if you observe, the QR complex distance increases and it ended up in a broad complex fused with T wave. We call sine wave pattern, and before that the first change is tented T waves. Okay, all these symptoms along with the tented T waves is more towards hyperkalemia. Right? What will happen? In a cell, the potassium is high on inside and less on outside. Right? So what happens if potassium becomes higher on the outside also? Usually there is an efflux restoring the membrane potential back. When there is increased potassium outside the cell, the gradient will decrease. Decreased gradient. This will cause the resting membrane potential to move closer towards threshold, or it becomes more positive. Okay. Truth about the condition is RMP becomes more positive. And if you want to know the reason for tented T waves in the ECG, it is about change in voltage per changing time rather than the movement of the ions. It is the change. So in a short span of time, there is lot of movement. Okay. Restoring the RMP will become quicker because of the gradient difference. Okay. Now I hope you understood why it is tented T wave. Great. False about the given image is. It is very simple. As you see the image, you can identify there are some cells which are shaped in the half moon. We call them sickle cells. Okay, sickle cell anemia. This one is. False about given image is oxygen hemoglobin dissociation curve shifts to right. Metabisulfate test is positive. True Rouleaux formation is seen. HB electrophoresis is global standard. We know this for sure. And oxygen hemoglobin dissociation curve shifts to right. Yes. Metabisulfate, it's a reducing agent, so it will cause sickling. It is also correct. True Rouleaux formation, no. True Rouleaux formation is seen in multiple myeloma like conditions where the plasma proteins like fibrinogen will all increase. Okay. But here there is stacking of RBC. There is stacking of RBC other than because of plasma proteins. This is due to adhesion. Okay. This is not true Rouleaux formation. There is false or pseudo Rouleaux formation. So this is the correct answer. Moving ahead. All are true regarding the condition in given image except. See, very simple. As you see this guy, we all see the striae, right? We see the moon face and we see the buffalo hump. It's classical of Cushing's syndrome. Cushing's syndrome. In Cushing's syndrome, if you know what will happen, difficulty in combing hair is a symptom elicited asking or evaluating proximal myopathy. The proximal muscles are used for combing hair. So, difficulty in combing hair will be there. Easily prone to fractures, yes. Increased in osteoclastic activity while decrease in osteoblastic activity lead to easily fracturable bones. And hypokalemia and hypertension. This cortisol has some mineralocorticoid action. It will lead to hypertension by sodium reabsorption and hypokalemia. And exacerbation of autoimmune diseases. See, in autoimmune diseases, we give cortisol to reduce the flare-ups. So, it will not cause exacerbation of autoimmune diseases. But withdrawal of some exogenous cortisol might increase the autoimmune pathologies, but it will not cause or exacerbation of autoimmune diseases in during Cushing's, okay, when the disease is there actually. One of the function of protein X is shown in the given image. Mutation to gene coding this protein causes all except, okay, it's a SLC gene that will code this. This protein is transporting iodide from follicle cell into the follicle lumen of the thyroid, okay, because iodine is important for thyroid. That is the first organ that should strike your mind. So this protein is pendred protein and the syndrome is pendrin protein and the syndrome is pendred syndrome. Pendrin protein and the syndrome is pendred syndrome. Where is this located? It is located in the thyroid, the pendrin protein, the inner ear and kidneys, okay, predominantly, and it is by SLC26A4 gene mutation. It will cause all except hypernatremia because it has no role in sodium reabsorption. Metabolic alkalosis it will cause because it will impair bicarbonate absorption, HCO3 minus bicarbonate absorption, and hearing impairment because it is a part of the endolymph transport and movement in the inner ear, and increased size of thyroid gland because it causes failure to synthesize T3 T4, increasing the TSH, which will stimulate the thyroid gland to increase the size, okay. In the given image, A is more than, if A is more than 0, okay, then in rest of the capillaries of the body what will happen? Here A pi, this space is Bowman space, okay, this is the glomerular capillary, this is the glomerular capillary and this is the Bowman space, right? That means pi here denotes oncotic pressure. Usually it is 0 because there is no filtration of protein. If it is more than 0, that means there is some damage to the basement membrane and the filtration of protein is occurring. If there is protein loss, the oncotic pressure will decrease in the circulation. That means the hydrostatic pressure and oncotic pressure balance will be disrupted, leading to the movement of fluid from intravascular compartment into interstitium, okay, from the blood vessel into the interstitium. So that is told over here, fluid moves from capillaries into the interstitial spaces. Hydrostatic pressure will not change at all, so these both are wrong. And fluid moves from tissues into capillaries, no, this is wrong. Answer is C. Enzymes deficient at 1 and 2 cause all except. See here we have a adrenal hormone synthesis flow chart, okay. This is very difficult to remember, right? Let us see what are the enzymes first. It is 17 alpha hydroxylase and 1720 lyase, okay. If you want to remember what is happening with this one diagram without remembering all of this, I can tell you one simple thing, that towards right side extreme, okay, extreme, there are estrone, estradiol, testosterone, they are sex hormones, male and female, extreme, okay. And in the longitudinally you have aldosterone and cortisol, which are important for everyone, so it will be there, okay. In 17 alpha hydroxylase deficiency, this step is gone. That means there will be decreased cortisol and there will be increased aldosterone, okay. There is increased aldosterone. If aldosterone increases, there will be hypertension, and there is also a chance that this will become androgens, and there will be amenorrhea. There will be increased androgen synthesis and there will be amenorrhea. Also, there is hypokalemia because of aldosterone. Potassium will be secreted into the tubule. So these three will be caused, but increased renin is the wrong answer. Moving ahead, function performed by structure in the later stage is taken over by. This is the X, function performed by X. Structure in the later stage is taken over by. We can see that at this stage, this is day 14 of menstrual cycle, there is ovulation. After ovulation, this will turn into corpus luteum. Corpus luteum will secrete progesterone. This is later secreted by placenta. Simple. That is identification and functional correlation. True regarding graph. So let us see. This is day 14, ovulation is there. A and B are two lines. Okay, A and B are two lines, two hormones. Okay, this A is estrogen, B is progesterone. I told you corpus luteum will be formed here and ovulation will happen on day 14, right? So for ovulation, you need LH surge. So making the other one FSH. Perfect. So this estrogen is required in huge amounts to cause LH surge, whereas microdoses of estrogen will inhibit luteinizing hormone. So A in low doses, this is A. Estrogen in low doses inhibits 1, that is luteinizing hormone. That is correct answer. Moving ahead. True about hormone with following pattern is all except. This is also a very good graph showing a diurnal variation of a hormone. At 8 a.m. there is a surge. At 8 a.m. there is a surge. Usually when we are suspecting Cushing's or something, we will ask for 8 a.m. cortisol. So the main hormone which is increasing after sunrise, that is 8 a.m. around, is cortisol, and during early hours is TSH or T3 T4. Okay, that is usually seen, thyroid hormone, in the early hours, that is around 4 a.m. and 3 a.m. like that. Okay, so all are true except binds to intracellular receptor. Yes, it's a steroid hormone. Increasing protein synthesis, we have a doubt because we have proximal myopathy. Next, increased blood pressure. Yes, of course, hypertension. Increases blood glucose. Yes, gluconeogenic hormone. So answer is B. Okay, increases protein synthesis, that is false statement. It causes proteolysis. Why does it cause proteolysis? For it to synthesize glucose for the process gluconeogenesis. So now we understand not all subjects are so much different from each other. Functional anatomy is needed, neuroanatomy, I've seen the Brown-Séquard syndrome, and here we need a biochemical understanding as well as reasoning behind knowing why it will cause proteolysis instead of protein synthesis. Okay, all the subjects are interrelated. It's a wide correlation. Moving ahead, all are true regarding the image except, see, this is a classical sign, we call it icterus. It is all yellow. It is seen in jaundice. So what will happen in jaundice? There is increased bilirubin. Which bilirubin will have high affinity to this sclera and why? Unconjugated will have high affinity because the sclera has elastic tissues to which unconjugated bilirubin will have more predilection to bind to. Looking at the options, glucurinated bilirubin is responsible. This is conjugation process, glucuronation, so it is not. Bilirubin has high affinity for elastin, true. Seen in malaria, hemolysis, yes. This can be a sign of hemolysis, yes. Glucurinated bilirubin. The answer is option A. Okay, moving ahead. True about the image is, see here we can see the bluish discoloration. We call it cyanosis. It is central cyanosis because it is in the tongue. Peripheral cyanosis is seen in the peripheries usually. Okay, the fingertips, nose, and all. Okay, peripheral cyanosis can be due to cold also, Raynaud's phenomenon. You know, right? And true, this is central cyanosis. See this funny option, will need immediate amputation of tongue. Oh, okay, no, it is not the option. Should not amputate. Blue color, no, don't remove. Next, impaired ventilation perfusion ratio causes this. Yes, this can be an answer. Let's move ahead. It is due to peripheral neuropathy. No. It occurs due to liver damage. No, liver damage causes icterus, seen in the sclera. So, answer is B. There is enough ventilation, that means the airflow is there, but the perfusion, the blood flow to the lung to accept the oxygen that is coming from the atmosphere has decreased. So this is impaired ventilation perfusion ratio causes. Identify the correct option. See here, regarding the Z point we have to identify. They marked it because it is also asked in the option. Z is play. Actually, this is a graph plotted against plasma glucose and glucose filtered, reabsorbed or excreted. This is in the nephron. Okay. Usually the transport maxima is around 350 for glucose, but the glucose starts to appear in the urine at 180 concentration in the blood. Okay, 180 mg per dl. Okay, but the transport maximum is 350. There is this difference because now two people are same, even both eyes of the same person doesn't look at an object in the similar way. Similarly, those millions of nephrons are not working in the same manner. One nephron might have 2000 transporters, other will have 1500 transporters. Some are young, some are old. Okay, so here this heterogeneity is the reason for the difference in the transport maxima and the reason for appearing of glucose in urine at 180 milligrams per dl. Okay, let us see. The substance is glucose. Yes, of course, here the plasma glucose is given. And Z is play. Yes, it is true. Okay, the phenomenon is due to heterogeneity of nephrons. Yes, the option is all of the above. Fine. So let us understand what is splay. See, the gradual rather than abrupt transition of physiological process from complete reabsorption to excretion. See, if the graph was plotted like this, okay, until this is the 0, let us say this is the 0, until some point 180 per se, it is 0 in the urine appearance and suddenly it has increased. So there will be abrupt increase in the urinary excretion of glucose. But is it happening? No. We can see here there is a difference. Okay, it is showing that slowly, gradually it will increase. So this difference, this tapering, narrowing down is called splay. The Oxford Dictionary meaning of splay is narrowing down. Okay, this will become splay. Okay. It occurs when a substance's filtration, reabsorption, or secretion reaches its threshold, but not all nephrons can handle it uniformly. That is heterogeneity. In the given X-ray, the neonate of diabetic mother suffered from severe dyspnea. Which of the following best explains the concept in the context? See, we can see here there is a haziness, whitewash lungs. It is a case of ARDS. In the neonate, it is usually due to surfactant deficiency, and diabetic mother history will say a lot about surfactant deficiency. Okay. Let us see the options. Larger alveoli have higher surface tension, increasing likelihood of collapse. Alveolar collapse is impaired, and impaired oxygenation are partly explained by the application of Laplace law. Very good. Surfactant deficiency decreases surface tension, contributing to alveolar collapse. Okay, not. Of course, it decreases surface tension, but it will not lead to alveolar collapse. Decreased alveolar compliance leads to increased airflow through the large alveoli. Of course not. Compliance means ability to expand with increase in volume with change in volume with change in pressure. So it's not. So the answer is B. Alveolar collapse and impaired oxygenation are partly explained by the application of Laplace law. Let us see what is Laplace law. Laplace law, it describes the relationship between the pressure, tension and radius of a curved surface such as alveoli. Even for cylinders also, in the vessels also you can apply. But here let us stick to spherical structure, that is alveoli, where tension is directly proportional or equal to pressure into radius by 2. Okay, that means pressure is equal to 2T by R. Right, pressure is equal to 2T by R. So more the surface tension, more the internal pressure. This pressure is the pressure within the alveoli. Okay, this is the internal pressure. Okay, and inversely proportional to the radius. So smaller the radius, more the tension. If you are, it is easy to pull someone quickly when they are close to you. Like, if it is very easy to bring something closer when it is close. So alveoli, if it is like this, it is easy to close. But if it is wide, it will take some more tension and internal pressure. Fine. All of the following physiological changes occur during acute phase of condition shown in the image. This is a classical MI. Anybody can diagnose. See here, ST elevations. Classical MI. Perfect. So here, increased sympathetic activation leading to elevated myocardial oxygen demand. Yes, it will lead to sympathetic activation and it will increase myocardial oxygen demand. Of course. Right. Upregulation of ATP sensitive potassium channels. Yes. When there is ATP depletion, this ATP sensitive potassium channels will open up and there is more efflux of potassium. More efflux of potassium from the myocytes. Okay, this is correct. Enhanced sarcoplasmic reticulum calcium uptake improving contractility in ischemic myocardium. How is it possible? No, it is not possible. It cannot be contract because it needs ATP, which is deficient here. So this is wrong statement. Elevated extracellular potassium due to failure of sodium and potassium ATPase activity. Absolutely correct. It is a okay, ATP dependent pump, sodium potassium pump. So it will lead to extracellular potassium increase. Perfect. The Z point observed in the aortic pressure waveform is primarily caused by, okay, see here, this is systolic, this point, and this is mean arterial pressure, and this is diastolic for the aortic waveform. Okay, aortic pressure which is represented in the waveform. And the Z point, there is a dip in the pressure. That means there is something that is transiently decreasing the pressure in the aorta. See, closure of mitral valve not related to aorta at all. Forget. Closure of aortic valve and transient backflow of blood. This is necessary for coronary artery blood flow, right? The only arteries which are filled in the diastole. So this is correct answer. Peak systolic ejection into the aorta? No, of course. Relaxation of the left ventricle and opening of mitral, not related. Perfect. The answer is B. Let us move ahead. Parkinson's disease is caused due to reduced function of which? You have all the parts named. A, pars compacta, B, pars reticulata. This is substantia nigra both together. And D is putamen, C is internal segment of the globus pallidus interna. We know that substantia nigra secretes the dopamine, which is responsible if deficient for Parkinson's, right? Out of these two, which will secrete pars compacta? Okay, this pars reticulata, it is a GPI. It functions globus along with globus pallidus interna. It functions as a single functional unit. Like means they are similar, much similar in function. Okay. Okay. So the answer is A, pars compacta. Perfect. Choose the correct option regarding the image shown below. They are showing some posture like this and something like this. So before understanding the flexion extension of the arms, just remember that red nucleus is responsible for the flexion at upper limbs. Okay, if the connection between red nucleus and the upper limb fibers is below the red nucleus is severed, that means cut, there will be no flexion but there will be extension. Based on this, let us see what rigidity is it. Decerebrate posture, that means the cerebral cortex entirely including red nucleus is cut off, and decorticate posture is above red nucleus and there will be flexion at upper limbs, and that means decorticate will have flexion. Is it there? Decorticate, is it below red nucleus? No, right? And decerebrate below red nucleus? Yes, which is B is decerebrate below red nucleus. Perfect. So B is the answer. Kernick sign and Brudzinski sign, it is not. It is for meningeal irritation in the meningitis when you flex the head. And this is Dolce phenomenon where you are moving the head right and left to check the brainstem intactness in a brain death or a traumatic brain injury case. Perfect. Correct among the following regarding the graph given is, let us identify. This is a flow volume loop curve of the lungs. Okay, flow volume loop curve. So beneath the graph, this is the inspiratory curve. Okay, it starts from 0 here and moves towards the center. It is the inspiratory curve and this is expiratory curve. Okay, the x is normal. The x is normal. Whereas the z and y you can see here, I'll change the color just a minute. Yeah, in y you can see that there is a short scalloping. It's a transient scalloping or concavity. Okay, transient scalloping or concavity here. This says it's an obstructive thing, because in the expiration the entire air should be expelled, but no, it has declined. That means there is some air trapping. Okay, COPD, right? That is obstructive. So y is obstructive and z is restrictive. How can we say? The entire volume is completely decreased. The lung is restricted from expanding as well as collapsing. So maybe there can be a slight increase in the expiratory flow, but the total FVC will be decreased and the FEV1 by FVC ratio may be normal or slightly increased. Normal or slightly increased. Got it? So we can say X is normal. Okay, where is it? X is normal, X is normal. Yes. Y is obstructive, Z is restrictive. Perfect. Got it? See? Obstructive, loop shift to left, volumes are more than normal, FEV1 decreases more than FVC, lower FEV1 by FVC. Restrictive, loop shift to right, volumes are less than normal, FEV1 and FVC decrease in proportion. That is why ratio remains normal or maybe slightly elevated. Okay. Cardiac tamponade shows significant change in which wave? See, before knowing what is what waves will be changing in the cardiac tamponade, you should know what are these waves. This A wave is for atrial contraction, right? C wave is due to bulging of tricuspid valve, TCV bulging into the atrium when there is contraction of ventricle. X dash is due to atrial relaxation after atrial contraction. Now tricuspid valve will close and it will bulge as the ventricle is contracting with isovolumetric contraction. Once the ventricle is contracted and the aortic valve opens, what will happen? This tricuspid wall initially, okay, let me give you an example. This tricuspid wall, which is initially bulged into the atrium, once the ventricle is emptying, it will go like this. It will become concave. That means sudden drop in pressure, as well as this contraction of ventricle, because this is the pericardial cavity, this is the ventricle which is contracted, and this is the atrium, right? Atrium, ventricle. This is contracting, this is decreasing in size, right? So there is some space that is extra produced in the pericardial cavity. So this space will lead to expansion of the atrium also. So this will cause second drop, that is X2. Okay, this is what is important. And we can see here the V wave is volume of right atrium due to filling. V is due to filling of the right atrium from the venous drainage, and Y is emptying, that is the passive flow of the blood from right atrium into the ventricle. So here we have in pericardial, in cardiac tamponade, that means there is some fluid in the pericardial cavity that will prevent the expansion of the or relaxation of the atrium. So X1 and Y, there is a huge descent of the X1, and Y will have slurred slope like this. Yeah, this is normal, and this is the slurred slope of Y, and there is a X descent, huge X descent, you call it. Okay. So the option here is X1 and Y. So these are the images that are required. I hope you understood the concept behind the discussion and all. Thank you for your time. I hope you enjoyed this session, and please leave your feedback. Thank you.